Let's roll. Good afternoon, everyone. Welcome to another wonderful episode here at Doctors of Podiatry. Today we're going to talk about something extremely common, a term that people may or may not be familiar with, and if they're familiar with, great, and if they're not, they're going to learn about what is a neuroma, right? A lot of people that present with pain on the bottom of the foot, it could be due to several conditions, right? When we look at our differential diagnosis of plantar foot pain, one of the things that comes to mind is the infamous neuroma, okay? What is a neuroma? A neuroma, and I want to be very, very clear, anything that ends in oma usually is perceived as a tumor, right? Lipoma, right? Glioblastoma, neuroma, and the neuroma actually it's not a tumor. It's in simple terms, it's simply an enlargement of a nerve, right? The nerve gets engorged, right? In between we don't have our model, but anyways, we do have the patient's foot. So we use it as a model. So in between, right, we have 1, 2, 3, 4, 5 metatarsals. And in between, right, in between, then we'll just make this one like this, like that. So in between the metatarsals, plantarly on the bottom, you have these common plantar digital nerves, right? And this is one right here. And when it gets to the area of the metatarsals, it splits, the nerve splits, right? That's what we call the little bunny ears. So one of them goes to one toe and the other goes to the other toe. And these are sensory nerves, which means that they're only for sensation. They provide sensation, not motor, which is very, very important. So what holds, right, all the metatarsals together is a ligament, which I've painted here in red, and that's called the deep transverse intermetatarsal ligament. And there are sometimes, if people are wondering, well, what exactly happens, right, to the nerve? So I've given you guys here, and I'm going to paint that now so you see the difference. This is normal, right? A normal nerve, nice and thin, then it splits, and then we have here, an engorgement of this nerve, right? This is the neuroma. Sorry about my penmanship, but that's the neuroma. So again, what is a neuroma? It's an inflammation of a nerve. Now, how do we deflate the nerve? I have a young patient who has presented with pain to the left foot, plantarly, of course, on the bottom of the foot. We sent the patient for an MRI, and the MRI revealed, drumroll, nothing. Yes, believe it or not, nothing. There are many times that we send the patient for an MRI to rule out a neuroma of either the second, third inner space, and it comes back normal. Why? One of my mentors always, and I was talking to the patient, one of my mentors always said, listen, you may or may not be able to identify the neuroma. Sometimes they're very difficult unless they are the size of a papaya, right? And in this particular case, we didn't see anything, but nonetheless, after the clinical exam, we've decided to conservatively treat this first, right? We're gonna go ahead and he already tried the cortisone injection in the past, and that really did not help him. Number 2, we're gonna go ahead and try an alcohol sclerosing injection. The analogy that I use is basically it's a taser type of injection where we basically inject the sclerosing solution, right? And it basically kind of stuns the nerve a little bit to try to see if we can just simply cool it down again right here. In addition to that, the reason why I drew the anatomy like this, the deep transverse intermetatarsal ligament, is because sometimes these metatarsals are so close to each other that they actually impinge on the nerve. So if they're impinging on the nerve, what happens? Bueller?
Swelling. Inflammation.
If the nerve is already inflamed and the metatarsals hit the nerve, it's going to reproduce what? Kind of like when you hit your funny bone and then all of a sudden you feel it in your fingers. That's exactly what happens. So one of the other minor procedures that we discussed was the release of this deep transverse intermetatarsal ligament, right? So if we go like this and we basically just snip it, right? We just cut it. Theoretically, at that point, this metatarsal, if they're so tight, this metatarsal will want to go this way, and this one will want to go the other way, right? And if the neuroma is in here, it's going to feel a whole lot better because you're providing more space for the neuroma to basically just go. That feels a whole lot better. Super. Last but not least, surgery. Surgical excision of the nerve. That's out of the question for now. We spoke about it, and obviously we're going to exhaust all the conservative therapies, and if needed, last resort, surgery. We excise the nerve, and that takes care of the problem 85% of the time. So what we're going to go ahead and do, again, I've basically done this for to show the public, right? We have 1, 2, 3, 4, 5 in this particular case. Again, what are we doing? We're looking for the metatarsal heads, which are back here, right? The ligament that we discussed is right around here. And the nerve, believe it or not, the nerve is underneath the ligament. So we got to get as close as possible to the nerve and then deliver a tiny little bit of that sclerosing solution. If anyone is wondering, well, why this, right? Why the sclerosing? What's so special about it? It denatures the nerve. It kills the nerve. Right? Different podiatrists do it differently. In my particular case, I like to start with one and see how the patient does. And if we need to do a second one, then we'll go ahead. Sometimes there's doctors and clinicians that do anywhere between 4 and 6 of these injections once a week. But I'm a more conservative individual. I don't like anything that's permanent. And obviously, what I was explaining to the patient as well is that, you know, this is it does damage. It causes damage, and it can cause damage to the surrounding structures. So that's why I'm a little bit more on the conservative side. We've already demarcated everything with our ultrasound, which is here, and I'll take the cold spray, right? A little bit of alcohol, and then at the end, I'm gonna say something that Wesley and I have been talking a lot lately about. Okay, and I usually tell the patient that they're going to feel a little bit of a stick, and then they're going to feel burning on the bottom of the foot, right? And just to please not kick me in the face or jerk the foot either. And here we go, okay? And a little stick like that. And we're going to go down, 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 very slowly, guys, very slow. This is very, very slow. Because I can feel right now, and burning, and a lot of burning, and a lot of burning, and a lot of burning.
Holy shit. Ouch.
We're gonna have to bleep that out. And we're done. Okay?
Whoa.
That's another thing. You guys heard the patient expressing his feelings there for a split second. Right? But I do it more on the slower side, the infiltration, just so that all that sclerosing solution stays in the area, right?